Well, welcome to Grand Rounds in Urology. My name is Morgan McDowell, and I'm a nurse practitioner in urology. I've been practicing for about 9 years in South Central Virginia. And today we're going to be talking about BPH, or benign prostatic hypertrophy. We're going to go over basically the AUA BPH guidelines and really focus in on evaluation and treatment of your patients. So let's get going. So you probably know where the prostate is, but do your patients? I find clinically that a lot of my patients really don't know what their prostate is or what it does. So just as a simple reminder here, your prostate is located between the bladder and the pelvic floor. Typically in most adult males, it's going to be about 20 grams in size. And it's part of the production in semen production in men. So BPH, as you probably already know, is the proliferation of the glandular epithelial tissue and smooth muscle and connective tissue within the prostatic transition zone. So when you think about that transition zone, that's kind of that center area or that water channel component of the prostate, right? And we see oftentimes a prevalence of lower urinary tract symptoms in our men as they age. So we'll see a 10% per decade increase in ages from 40 to 80. And as our population continues to age, we're going to see more and more of these symptoms over their lifespan, right? So 50% of men in that 51 to 60 year age range are going to have symptoms of BPH, and usually 90% of men over the age of 80. Now, we use a lot of terms to describe these symptoms in men. So we want to take some moments here to really kind of fine tune these in your understanding of these words, because some of them we use interchangeably and some of them we do not. So BPH is going to be that symptomatic histologic diagnosis of men with these lower urinary tract symptoms with that larger growing prostate gland. Benign prostatic enlargement is typically defined as prostate volume greater than 30 centimeters. And you're going to typically see that once you have some sort of imaging that will define the size of the prostate gland itself. Benign prostatic obstruction is typically a diagnosis that we give folks after they've had pressure flow studies or potentially urodynamics that indicates problems with that flow rate, and particularly if that prostate gland is enlarged. And we often use this word too interchangeably with the next diagnosis, bladder outlet obstruction. And this is a generic term that we use for all forms of obstruction to the bladder outlet, including the BPO. Okay. And so think about that LUTS diagnosis as well. Lower urinary tract symptoms. This is one of these great words that's really all encompassing of the irritated avoiding symptoms that we can see actually in men and women to some degree. And then overactive bladder, classic symptoms of urgency and frequency with or without urinary incontinence. We see this a lot in men, and it can coexist often with the BPO or BPH symptoms as well. Detrusor overactivity is more of a diagnosis that we usually get during urodynamics, because you can see this in your urodynamics study. And this will be truly detrusor contractions that you can pick up on the filling phase, and they can either be spontaneous or provoked. So this is normal kind of male development in some ways. I tell my guys in clinic that the older you get, maybe your belly's getting bigger too. Well, your prostate's going to get bigger as well. And that's okay. What we want to manage are those symptoms that come along with it. So this is, again, is a very common condition in the older male. By the 6th decade of life, at least 50% of those men are going to have some degree of hyperplasia or that prostate enlargement. By the 8th decade, at least 90% of these guys are going to have that increased prostate size as well. Somewhere around 10% of these men are going to require surgical or medical intervention. And I'm sure you've noticed this if you're getting into urology practice, is that men have a tendency to minimize their symptoms. And so you want to manage BPH kind of early before it gets to that no return point. So think about a 55-year-old male who's coming to clinic. On their DRE, they have a 30 gram prostate, right? And experiencing some symptoms. His PSA is normal at 1.5. So expect his prostate to approximately double in size over the next 15 years. So if symptoms are minimal now, they're going to be worse in 15 years for sure. So how do we diagnose BPH? So for this, we're going to look at the clinical principles within the AUA guidelines for BPH, and our initial evaluation is going to be fairly straightforward. You're going to get a medical history on the patient. Complete a physical exam, urinalysis, right? It's urology, so we're checking urines on most all of our patients. A post-void residual to see kind of what that incident of incomplete bladder emptying is. Voiding diaries can be incredibly useful tools too to help you evaluate BPH if your patient is maybe not a great historian. That urine flow rate component as well, and that arc of the flow. We'll look at a sample image of this later on, but this is kind of your clinical principles within the guidelines of how you're going to diagnose BPH. So, one of the really amazing tools out there for BPH and symptom kind of evaluation is the International Prostate Symptom Score, or the AUASI. I use this on all of my BPH patients to have a better understanding of like where they are within their symptoms and how treatment is going. So, some of the things we look for, maybe that we talk about, is that weak stream component. Do they have an intermittent stream with hesitation? Do they drip and dribble now? And do they have any of that urinary retention component, right? So these are really important. And we love asking about the nocturia. That can also be a really great indicator of BPH. So your patients are going to score their International Prostate Symptom Score as mild, moderate, or severe. And that's going to help you as a clinician decide kind of what you're going to do for your treatment. So when you're thinking about these patients in clinic, you're going to do a focused physical examination. You're going to do an abdominal exam, assessing for tenderness, masses, or distension, right? And you've gotten a PVR. So is that distension related to a full bladder, or could that be something else? Your neurological components too, right? What's your patient's ambulatory status? How physical able and capable are they? And neuromuscular function can be a component of this as well. You'll find oftentimes that patients with MS or Parkinson's disease typically have pretty significant LUTS. Genitourinary exam, of course, these are your male patients. So you're doing that really great exam to look for any abnormalities like a meatal stricture or something like that. And then, of course, you're going to move forward with your DRE as well. The bladder diary can be really helpful for sorting out your patient's symptoms. Sometimes, again, your male patients maybe are not the best historians. And when you need better information from them, sometimes sending them home with a bladder diary is a great way to get it. So you're looking for things like voiding frequency. How often are they going to the bathroom while awake and overnight? And what's that total voided volume out with voids, right? And I love this too, because often it'll tattle on, what are their fluid intake situations like? Are they drinking, 2 pots of coffee in the morning and that's what's causing their lower urinary tract symptoms? Or, are they not drinking enough and kind of getting really too dehydrated in that really concentrated urine that can be just as irritative to the bladder as well? So you're going to look at that voiding frequency. You're going to alert patients to their habits and then opportunities to modify. And one of the great things too, again, is you can repeat the voiding diary or the bladder diary once you've implemented a treatment to see if that's been an effective way too. Again, great tool to utilize in clinic. This is a really great example of that flow curve that we talked about with the flow rates. So if you can see here, the black line is the normal urinary void curve. So it's got this beautiful arc from the bottom to the top, beautiful curve, right? So if you look at the blue line, which is more squiggly, kind of stop-starty in some ways, that, if you can imagine, is that patient with urinary hesitancy and kind of that weak stream. So a good indication that they've definitely got more of those lower urinary tract symptoms that we would associate with BPH. And if we look at our treatment options, so again, going back to those guidelines for BPH with the AUA, we're going to first always start with behavior and lifestyle modifications, right? So is that timed voiding? Do we need to remind our patient that they need to be going to the bathroom every 3 to 4 hours instead of trying to hold for 6 to 8, right? A lot of our male patients will suggest, instead of standing to void, that they go ahead and sit down to void to have a better and more complete emptying. Double voiding can be very helpful in this case as well. So you'll have them void, stand up, sit back down, void again. And bladder irritants are huge. I tell my patients constantly, the older you get, the more sensitive your bladder becomes to things like caffeine, alcohol, caffeinated beverages, and then the bubbles and whatnot. So it's really important that folks are aware of that and change their diets a little as well. We'll review medication therapy for BPH treatment today, as well as all the surgical procedures out there. So it's important as a prescriber, an advanced practice provider in urology, that when you think about prescribing medications, you're thinking about what it is you're actually treating in the body. Like, where is the mechanism of action of the medications to ultimately impact the side effect that's bothersome to your patient? This is a really great image that talks about the medications we're going to review next and where they work between the bladder and the prostate. So your first line therapy for BPH is going to be your alpha blockers. That could be a drug like alphazocin, doxazocin, tamsulosin, or terazosin. These are great drugs because they work fast. Most patients are going to see some symptom relief in 2 to 5 days of starting this medication. Some of the side effects, though, can be a little tricky for some of your patients for sure, right? Dizziness, the orthostatic hypotension, fatigue, ejaculatory dysfunction. And another thing to really consider is floppy iris syndrome. And this is incredibly important if your patients have cataracts and are going to be moving forward with cataract surgery. So you're going to want to ask about a recent eye exam, or whether or not that patient has cataracts before prescribing one of these medications. Another medication in the BPH realm is going to be your 5-alpha reductase inhibitors, such as finasteride or dutasteride. These medications are great. They shrink your prostate over time, but they're slow, usually taking 3 to 6 months to really get moving. The side effects of these medications include decreased libido, ED, sometimes gynecomastia, depression, and it's usually best for prostates at least 40 grams or bigger. This can be used in dual therapy with the alpha blockers as well, and sometimes it's a great option for these therapies as well. So the alpha blockers are really considered the best monotherapy for immediate symptom relief, right? They're going to work fast. We typically recommend folks take these medications at bedtime or after dinner to help avoid some of that dizziness and the orthostatic hypotension. The 5-alpha reductase inhibitors are really great at preventing long-term disease progression. The thing about it is folks need to stay on those meds, right? And when they get that symptom relief in 3 to 6 months of being on maybe dual therapy, sometimes they'll stop the medications thinking, well, I'm cured, I'm fixed. But ultimately, most of the time when folks are going on these medicines, this is kind of lifestyle long-term BPH therapy, right? The conditions aren't necessarily going to get better. So we do have to reiterate to folks to stay on these medications, right? So a lot of times we'll utilize combination therapy for symptoms and progression of BPH with that moderate to severe symptoms, and think about the scoring that maybe that individual got on their International Prostate Symptom Score. And so we know also that the evidence indicates that combination therapy is most effective in those with more marked prostate enlargement. So great drugs overall. I get a lot of questions about the cost of these medications. And thankfully, these medications have been out for a long time. So most of the insurance plans in my community cover them quite well, or they're relatively inexpensive to be purchased out of pocket because they offer great benefit to the patients with BPH. There are additional medication options to treat BPH as well. So you can actually treat BPH in some patients with phosphodiesterase 5 inhibitors. As you may already know, tadalafil 5 milligrams daily is indicated for BPH. The side effects of this medication include headache, flushing, and back pain. And so great option for some folks for sure. Sometimes if they have the concurrent ED, this is a great option to do maybe dual therapy. But you can also use this in patients who do not have erectile dysfunction as well. Another component of the guidelines is that with folks who have overactive bladder components to their symptoms as well, particularly with that moderate to severe storage lower urinary tract symptoms, so urgency and frequency components, you can utilize anticholinergics and the beta-3 medications in these patients as well. And Vibegron has recently moved forward with an FDA indication to be utilized in men with OAB symptoms also being treated for BPH. So as time has moved on, we've gotten more therapies in terms of oral medications for patients to utilize to treat their BPH, which is good news because we always want more options. So anytime you're going to start a therapy on a patient, it's wise to follow them back up in a timely fashion to assess how that intervention is working for them. So typically going to follow up in 4 to 12 weeks, depending on what medicines you put your patient on, right? Sometimes you may wait a little bit longer, maybe closer to that 12-week mark if you're putting the patient on a drug like finasteride and you're looking to shrink the prostate, because again, that's just going to take 3 to 6 months to work. A lot of times at the follow-up evaluation, I want to repeat the International Prostate Symptom Score to get that really good data and that objective analysis on how the patient is doing now, right? And we can compare those scores over time and trend them to see if we're improving or not improving. Often we'll repeat a post-void residual and potentially repeat a uroflow as well. So within the guidelines, if that patient comes back to you and they're not any better, they're like, this is no good, this medicine hasn't helped, we might require additional evaluation of that patient to include things like cystoscopy, transrectal or abdominal ultrasound to get a really great measurement of the prostate, potentially cross-sectional imaging and urodynamics. And this is all within your AUA BPH guideline. What's really interesting to me in the BPH world is we've had surgeries that have been around for a very long time. Now, you might already know about TURP, but TURP is still the gold standard procedure, and it's been around since 1929, which is pretty darn impressive. But really, in the last 10 to 15 years, there's been so much development of minimally invasive, lower risk procedures for men with BPH. So we have a lot of opportunities for guys who maybe don't want to jump all the way to TURP as a procedure for their BPH and their symptoms. It's really impressive. The market has changed a lot just since I've been in clinical practice. And so let's review some of these more closely. So you'll see here, I have a list for you of like how these surgeries are kind of lumped together in terms of what they do. You've got your missed procedures, your resection procedures that are going to actually remove prostate tissue itself, laser enucleation. We've got prostatectomy still, although I don't think many folks are moving to prostatectomy for BPH real often these days. Prostate vaporization, water jet resection, and arterial-based procedures. So the technology, as you can see, has just come really far. And the goodness here is that we've got a lot of options for patients to choose from when they're looking for a procedure. So what are the indications based on our guidelines about when to move a patient to surgical intervention? And I think this is important, right? So you've got a patient who is renally insufficient secondary to BPH. So oftentimes these folks will maybe already be in retention and have that big bladder that's maybe moving its way to not working really good due to long-standing outlet obstruction. So oftentimes we'll move forward with a procedure to open them back up so we can get some of that pressure off the kidney and preserve that kidney function. Folks that are refractory to urinary retention secondary to BPH, right? So you've treated them with your alpha blockers and your 5-alpha reductase inhibitors. You've given them time for the medications to work, but you can't maybe get them out of a catheter or off of continuous self-catheterization. So maybe those folks are interested in, at that point, in moving to a surgical procedure. Oftentimes, because of the risk with the elderly population, with recurrent UTIs, we're considering moving to a procedure as well to kind of open that prostate back up to reduce that post-void residual and reduce risk of infection. Recurrent bladder stones or gross hematuria to BPH are also an indication. Anytime you have a male patient with a bladder stone, that's a good sign that they've had long-standing outlet obstruction as well, right? So we need to do not only treat the bladder stone, but really go ahead and remove that prostate obstruction as well so that they can pee and empty more appropriately moving forward. And then with those lower urinary tract symptoms that are attributed to BPH but refractory to other therapies, or maybe you have patients at this point who really don't want to be on these BPH medicines secondary to their side effects. They come with a lot of sexual side effects, as we've already mentioned. And a lot of gentlemen are sometimes really just not interested in that and want to move forward with the surgery. What's really important when you start thinking about surgical options for your patients, the size of the prostate and the volume of that prostate really does matter. It matters what lobes are impacting the patient in terms of their voiding function. And so it's really important to better understand the size and morphology of that prostate. So you're going to want that prostate volume and to know whether or not there is that intravesical lobe or not, right? And you're going to get that information usually through your maybe your transrectal ultrasound and the cystoscopy. Typically, you want imaging prior to surgery within 12 months, right, to get that information. And so your prostate volume is usually developed or calculated through the ellipsoid formula that is written here for you on this slide. And a lot of your ultrasound machines nowadays will help you calculate that for you. So you don't have to do it yourself most times. So it's important to note that a lot of these surgical options are dependent on the prostate size of the individual for best outcomes, right? And so to get a closer picture of this information, this is all outlined really nicely in that AUA BPH guideline as well. So, for example, like a TUIP is ideal for patients with a less than 30-gram prostate without that median lobe. MIST procedures typically do better in that 30 to 80-gram range for patients, and they may or may not have a median lobe. My physicians would be happy for me to remind you that TURP is still the gold standard procedure for men with BPH, and typically in that 30 to 80-gram prostate range with a median lobe, of course, if they have that. Aquablation is a really cool procedure that's it's newer, but a fantastic option because you can treat much larger prostates with aquablation up to 150 grams, including that median lobe. The enucleation procedures can do prostates 80 grams or larger as well with median lobes. And then when you're thinking about your open simple prostatectomy or your robotic prostatectomy, those procedures can treat very large prostates as well. Let's dive into some of those. So the robotic or open simple prostatectomy is an open procedure, usually suprapubic or retropubic incision. And a lot of times now, because of the Da Vinci robots, we're seeing much more of this done as a robotic procedure versus open. We know that robotic procedures have a tendency to be safer in terms of their complication rates and whatnot, particularly in the idea of like transfusion or the patient requiring transfusion. But really, a great procedure for some, right? So, an indication here is going to be for very large prostates. We'll typically see outcomes where the prostate symptom score is improved significantly, usually dropping anywhere from 18 to 22 points. Usually, urinary flow is improved as well, that you'll see on your uroflow. But again, think about those complications. This is a major surgery, right? Major abdominal surgery. So that transfusion rate with open cases is up to 10%. And again, you're going to see that drop pretty heavily with robotic cases, but you can certainly have more incontinence. And one of the benefits of robotic surgery is typically that shorter recovery phase. A lot of these men will have some sort of stress urinary incontinence after this procedure, and it can continue. And some erectile dysfunction as well in 1 to 3%. This procedure was first done in 1945, so an oldie but a goldie, and still around. Typically in the postoperative phase, folks are going to have a Foley for a period of time too, while this area is healing. And so they'll go home for that Foley, usually coming back to clinic in maybe 7 to 10 days for voiding trial, but good procedure overall. So next up is the TURP, and this can be a monopolar or bipolar TURP. And it's a resection of obstructing prostate tissue via a cystoscopy with a wire loop. And so some of them use kind of a slightly different conductive field. So monopolar uses non-conductive fluid, whereas bipolar uses a saline, which is considered safer in some ways. Indications are still at 30 to 80 grand, often with a median lobe. Originally, this procedure was first done in 1926. So again, been around for a very long time and still kind of the gold standard. A lot of the newer procedures are compared to this and are still considered, TURP is still considered one of the best procedures overall. So Overall improvement is pretty impressive as well. We'll see that International Prostate Symptom Score drop significantly. The Qmax is improved with the uroflow, and it's usually very durable, right? There's a very low risk of reoperation, only in 2 to 5% over 5 years. Most of these gentlemen are going to go home with a Foley catheter 3 to 5 days after procedure as well. But we'll see a lot of potential side effect risk in terms of that erectile dysfunction. There is a higher risk for the monopolar therapy to require transfusion, and there's a very less likely to experience but a TER syndrome, which can happen after this procedure as well. We see this a lot less these days because most surgeons are using the bipolar method for TER. So again, a small risk of transfusion is needed, but most guys are going to do well with this procedure and ultimately be satisfied with their outcomes. So again, very low risk of reoperation with these folks at the 5-year mark. Transurethral incision of the prostate is another procedure as well for BPH. So this is 1 or 2 incisions made from the bladder neck into the prostatic urethra to reduce that bladder outlet resistance without removing tissue. So you're kind of just opening up the prostate with basically making some flaps to some degree. So indicated for small prostates, less than 30 grams with no median lobe. Oftentimes we'll see prostate score improvement by 9 to 13 points. And again, improving that Qmax on uroflow as well. So complications include lower transfusion rates and ED rates as compared to other procedures like TURP. But overall, a good option for some patients with small prostate. So then we move to our laser enucleation procedures for your patients. And so enucleation happens with the adenoma with the holmium or thulium laser followed by morcellation, right? And it's similar to open prostatectomy, but this is an endoscopic procedure. So we're reducing a lot of our risks because it's not an open prostatectomy case. Indications for that greater than 80 grams large median lobe. Outcomes improvement in that International Prostate Symptom Score. Qmax improvement with uroflow can be significant as well, with really kind of improving overall urine flow, low reoperation risks, and things of that nature. So one of the bigger side effects with this procedure is going to be stress urinary incontinence, and urge urinary incontinence is something to look out for. Oftentimes, you have to remind your patients that after any prostate surgery, there might be a rebound of symptoms, right? That bladder doesn't know, and the bladder's a muscle, so it's trained to behave a certain way, that we've kind of changed its situation, right? By changing that prostate. I tell most folks, give your bladder 6 to 8 weeks to figure this out because it's going to get a little strange and you might be frustrated for a little while, but give the body some time to recover and that bladder will usually kind of get it back up to normal. So with these procedures, typically a Foley is utilized for 1 to 3 days after procedure. And again, we're going to give our guys time to recover ultimately and let the body heal because again, sometimes they'll have that urgency frequency symptom after surgery and they're not really happy if they have that episode of incontinence even. So just remind your folks, it's going to take some time. So another procedure for patients with BPH is going to be your prostatic artery embolism. This is pretty cool. So this is performed by interventional radiology, and they go in and selectively embolize the prostatic arteries via the femoral or radial artery access using microspheres. It leads to ischemic necrosis and subsequent prostate shrinkage. So we're literally cutting off blood supply to the prostate to shrink it, right? So prostates greater than 40 grams, patients with high surgical risk or prefer minimally invasive options, this is a good option for them. We recently referred one of our patients out for this, and he was a significant cardiovascular risk, so not a good option to go to the OR with us, but was a great option for this. And so he wanted to move forward with this as a therapy, which is a great idea for some folks. So prostate improvement score, because again, this can kind of take a while for that prostate to shrink after the procedure itself. That is variable to some degree, so we can drop that score from 9 to 21 points. Qmax improvement is mild to moderate. And the volume of reduction is usually 20 to 30% of the central gland of that prostate. And so you'll also, in this case, see a drop in the prostate antigen. So when you're looking at PSA lab values, you should expect to see a large drop with these patients. Complications include things like hematuria, pelvic pain, potentially urinary retention, and a major rare side effect could be a non-target embolization where they accidentally get something that impacts the bladder or the rectum. And so a reoperation rate in this case is up to 20% at 5 years. So non-targeted embolization leading to bladder necrosis can happen in less than 1% of the patients. Same thing with rectal ischemia or penile. So again, very rare side effects, but this could happen to your patients. Most patients report early improvement within 1 to 2 weeks, and you'll see kind of that continued improvement over that 3 to 6 months period while that prostate is shrinking down. So overall, a reasonable choice for some patients who may not otherwise be surgical candidates. UroLift is also one of our newer procedures in the market. So this is a prostatic urethral lift. And basically this procedure, the surgeon goes through the water channel itself and inserts transurethral implants that retract the lateral lobes of the prostate. So where you're literally like clipping open the prostate. I think you can see that pretty well, like in photo H, where you can see like 2 clips on the right and 2 clips on the left lobe of the prostate there. Again, opening that water channel up so we're not peeing through that pinch straw or that narrowed tube anymore. Indications typically of prostates less than 80 grams without a significant median lobe. Typical outcomes include prostate symptom score drop for 9 or so points and improving that Qmat. Some of the complications of this procedure is that patients can have some dysuria with voiding. They can have hematuria and pelvic pain. One of these symptoms, this prostate procedure is pretty interesting because it's minimally invasive and it's usually an outpatient procedure, which is nice for a lot of your folks. It does preserve sexual function, which is also something that our younger patients may be looking for. So that's a nice feature of procedures like this. And so, but consider that as the prostate continues to grow in size, there is a risk of reoperation in about 14% of the folks at the 5-year mark. Resume is now on the offering table for our BPH patients as well. So water vapor therapy is a procedure that utilizes transurethral steam injection causing cellular death. Okay. So these patients are going to have symptom reduction over 6 to 12 weeks as that cells die and they kind of open that water channel back up after that cellular death component, right? So indications of prostates less than 80 grams, including the median lobe, can be done with this procedure, typically noting a drop in International Prostate Symptom Score of about 11. Again, improving that Qmax with uroflow. So complications include things such as dysuria, hematuria, frequency and urgency. And again, there is a small risk of having a reoperation at 4% in those 5 years. And I realize the picture is probably a little small on this image here today, but I hope you can see that from the beginning, you've got BPH and kind of that overgrowth of prostate tissue in the transition zone. But after the procedure, that tissue has died back, right? So you've had that cellular injury because of the steam, and that tissue has died back and opened up that water symptom, opened up that water channel. So oftentimes some of the other side effects include UTIs, hematospermia. Most of the symptoms after this are mild to moderate, and most are going to be resolved within 3 weeks. So one of those other components where you're telling your patients is just hold on, your symptoms will get better because maybe they're going to get a little worse after procedure. But Resume was approved in 2015 as a therapy for our patients with BPH. So a really interesting option for folks as well. We also have transperineal laser ablation. And how does this work to treat BPH? So this has to do with laser fibers are inserted transperineal under ultrasound, and the laser causes this coagulative necrosis in the transition zone to relieve obstruction. So again, we're going to be killing tissue in the prostate to make it go away, right? So the indications for this is that there's a 40 to 100 gram prostate. One of the benefits of this procedure is going to be that ejaculation is preserved. So that's important when you think about your younger guys who are concerned about sexual function. Post-op is typically with a Foley for 1 to 2 weeks to, again, let this water channel heal, let the procedure work its efficacy, right? And it just takes time for the tissue to go through that process, maybe 1 to 2 days in the hospital, depending on the age and overall wellness of that patient as well. But typically a nice improvement in prostate symptom scores, your Qmax related to your uroflow as well. And again, most of those patients are going to have preservation of the ejaculatory function. Other side effects or complications, though, include transient dysuria. Again, not unusual considering kind of the procedure and what we're doing to the prostate, that dysuria would be a component of that. That perineal discomfort because of the approach on this procedure as well. And we don't have good long-term data about retreatment rates or reoperation rates just because this is a newer procedure. So overall, new option for patients that may be offered from your surgeons for your BPH patients. The transurethral electrovaporation of the prostate, or TUVP. This is a procedure that is technical electrosurgical modification of the standard TURP procedure, right? Utilizing a variety of energy delivered surfaces, including a spherical rolling electrode, a grooved roller electrode, or hemispherical mushroom electrode. So it's designed to improve tissue visualization, blood loss, and resection speed. So we're treating tissue a little differently in terms of the TURP, right? So whereas that's the cautery loop, this is just another tool that's performing kind of cautery in a slightly different way. So indications here are the 30 to 80 gram prostate with a median lobe, seeing significant improvement in International Prostate Symptom Score, as well as uroflow with Qmax. These folks are going to have a Foley for 2 to 4 days after surgery, potentially longer. Incontinence is a big risk with this procedure. Erectile dysfunction, 6%. Transfusion rates are potential there. And then reoperation rates are going to be similar to that of TURP because, again, of how the procedure is managed and really what we're doing overall to that tissue there. Aquablation is a relatively newer procedure as well. It is robotically executed treatment with high velocity saline jet to ablate the prostate tissue under real-time image guidance, typically utilized in prostates with 30 to 150 grams, including that larger median lobe. Outcomes included a really great drop in International Prostate Symptom Score, as well as an improvement in the Qmax. Complications include incontinence and reoperation potential at 4% at 5 years. Post-operatively, we do see folks with a Foley and continuous bladder irrigation. Symptom relief typically comes at that 1 to 2 weeks after procedure. They're seeing with this procedure a volume reduction in the prostate at about 36% at 6 months. And again, we're going to see a drop in PSA with this procedure as well because we are damaging and basically removing that prostate tissue. So interestingly enough, this is a quick procedure too. So the average ablation time in some of the studies was just about 8 minutes. And so that's pretty impressive overall, right? When we're able to reduce surgical time and the time on the table for patients when they're under anesthesia and things like that. So something to consider for your patients potentially if this is offered by your surgical team. There's a little video there, if that's activated now, to kind of show you how this procedure mitigates some of that prostate tissue. Hopefully you can see that on your screen really well. But as you can see, that prostate tissue is just kind of disappearing, right, as we're ablating the prostate. Another procedure that is newer in the market is FDA de novo class of 2020 is the I-10, or a temporary implantable nitinol device, and this is indicated for prostates less than 75 grams with no median low. Typically, these folks are going to have a fully 5 to 7 days after the procedure. And outcomes include reducing the International Prostate Symptom Score and as well as a mild improvement in uroflow with the Qmax. So you can see from the picture here that this product is a temporary implant that is applied to that prostatic urethra. You can see here in the top photo how it opens up that prostate and then afterwards. So once placed, it self-expands, applying radial force to the tissue, causing controlled ischemic necrosis. This results in incisions that reshape the bladder neck and the prostatic urethra, improving urine flow over time. Some of the benefits of this include that this procedure is done under light IV sedation using a cystoscope, and the device is advanced into the bladder and carefully positioned so that the anchoring leaflets sit at the 6 o'clock position just below the bladder neck. No catheter is needed, and the patients typically go home the same day. After 5 to 7 days, the device is removed in the outpatient setting using a catheter and a retrieval wire, and the device is pulled back into the catheter and withdrawal, completing the treatment. So complications, potential, but usually self-limiting include hematuria, urgency, pain, dysuria. But most, again, those symptoms occurred in the short term in that less than 7 days or 8 to 20 days. UTIs are a risk anytime we're impacting the water channel. And that was noted in some of these patients in the original study, but were successfully managed with oral antibiotic. Urinary retention also occurred in some cases with the study as well. 5 cases occurred when the device was in place themselves. And 4 of these 5 patients were succeeded successfully by entering the bladder with a temporary replacement of a Foley catheter. So in one case, the device was removed 24 hours after implantation, and the patient was then successfully able to empty their bladder on their own and did not require any sort of follow-up surgery. So I think we'll see more about this procedure in the future. Optilume BPH is a drug-coated balloon dilation. So Optilume BPH is a novel MIS procedure that combines mechanical dilation with delivery of medicine to treat LUTS and BPH. So the balloon dilation with this coating is opened up into the bladder. So you can see that here on the image of the procedure itself. There is immediate urethral widening and drug-delivered durability. So this is utilized in patients with 80 grams of prostate or less with minimal median lows. Typically, after this procedure, patients are going to have a Foley for at least 2 days. We'll see an improvement in International Prostate Symptom Score as well as that Qmax. It's important to know here that this procedure itself separates the lateral lobes of the prostates, while the medication delivered is intended to maintain patency during the healing process, which is why you want that Foley catheter in place. But this procedure itself was FDA approved in June of 2023. So you can see here from this picture that it appears to offer really great opening up of that water channel. So some summary and takeaways. BPH treatment is evolving in many ways. As you can see, there are kind of new medications that are a part of the FDA treatment guideline, as well as the AUA treatment guideline for BPH. There are new and exciting things coming down the surgical pathway for BPH as well. You know, going all the way back to the TURP, which is the gold standard and a really fantastic procedure for lots of men. It's an awesome thing that we have new procedures so that folks can decide what works best for them and, you know, what do they have going on. So when you think about these procedures as an advanced practice provider and you're advising your patient, you know, what are their symptoms? Go back to that symptom score. What are they complaining about most? You know, where are they seeing benefits and where are they not? Think about the prostate size and the morphology of that prostate. Are there surgical options that make sense or that they can choose to participate in and maybe aren't going to be as effective for them given their prostate size? That's important that you have that conversation with that patient. And remember, there's always patient preference and comorbidities, right? I think about my younger patients. You know, it's really important to them to save that sexual function. So TURP for them really maybe isn't as appealing as it might be for someone who's much older. So the good news is you've got lots of opportunities to educate your patients and offer them kind of this really great cornucopia of options for treating BPH that are going to meet that patient's needs for their symptoms and what they have going on, but also to hopefully afford them really great outcomes to get them where they want to be in terms of their bladder and their prostate symptoms. So just remember, as an advanced practice provider, you play a key role in the evaluation, education, and management of your BPH patients. And here are our references today for our slide deck. And we want to thank you for participating in our grand rounds in urology today.